Dr. Anil Jain is invited. Thank you, Dr. Anil Bhai.
Good afternoon, everybody, and I thank the organizing committee for having given us this opportunity to make a few presentations here. Dr. Anup just now gave a very great detail on how medically we can manage heart failure, but there is one point of time where medicines will play their role and still the progressive disease overtakes it. Like, for example, if the patient gets admitted today, he is a diagnosed case of heart failure. Heart failure is a progressive disease. You cannot stop it. As time goes by, the frequency of episodes of heart failure increase, hospitalization increases, and one day finally the patient dies. So in between somewhere, if possible, some sort of a therapeutic or surgical treatment should be given so as to prevent his death or mortality of this patient. So what can you do for heart failure? Can surgery help? You're all family physicians, so I'm not planning to make you surgeons, but I'll just give you a little idea of what we can do surgically to help these patients who fail on medical treatment. So we all know transplant is the most glamorous thing. Yeah, there's a patient with heart failure, get him, change his heart, put a new heart with the normal ejection fraction and send him home. But can transplant be given to everybody? No. The number of patients with heart failure in any country is far greater than the number of hearts available. For example, India has an incidence of 0.5 to 1% of its population suffering from heart failure. So we can never give a heart transplant to everybody. This will, of course, will be for strictly screened population, maybe the young patients, patients who don't have nephropathy, who don't have any sort of cancer, who don't have any other sort of comorbidity. They are the ones who will get a heart transplant usually. So for the remaining, there is something else to be done. And heart failure usually goes like regional. For example, Gujarat hearts will stick to Gujarat, Rajasthan hearts will stick to Rajasthan. Some sort of a network is there to be able to give hearts. So only patients who are very compliant, who are going to follow a strict lifestyle, who are young, who don't have comorbidities are the ones who are going to get a heart transplant. The remaining, we'd have to look for something else. And in fact, if you're going to treat a population for heart failure, you have to have something other than transplant. Transplant is glamorous, it is very good, it is very nice, but it has its own set of problems too. So to understand non-transplant treatment of heart failure, I just want to remind all of you that the heart is like a rugby ball. It has its certain size and shape. And we all should remember the Frank Starling principle for the heart contraction. As the heart dilates, the effective contractility keeps coming down. So that means if the heart changes its shape from a rugby ball to a football, then it starts failing. So the idea is to try to bring down the heart size by any way or any surgical therapy. So this is what happens. Basically, if the heart is in its nice elliptical shape, the contraction is good. If the heart changes its shape, it starts failing. So surgical treatment depends on the shape of the heart and the size of the heart. Again, this is what happens. If the heart dilates, the papillary muscles are pulled down, mitral regurgitation starts, and again that leads to worsening heart failure. So if we are trying to treat a failing heart, and why do I make this point to all of you? At one stage, we all believe that it's a very sick heart, 15% EF or 20% ejection fraction or hugely dilated heart. No treatment is possible. This person is destined to die if he doesn't get heart transplant. But that's not true. A lot can be done surgically for failing hearts. I get this question, 10% EF, 5% EF, 20% EF. Can you do something? And we regularly treat these patients. So it is this set of patients which we should not let them die, and in fact try to do something for them so they live a better quality life also, and they live longer also, and they're not in the hospital. First is coronary bypass surgery. Very frequently, 10% EF, 15% EF, 20% EF, they're just said you are inoperable. Not true. Patients who have small hearts, viable myocardiums, we should evaluate them and they can have surgery. So it is not that any patient who has ischemic heart disease and a bad heart should be allowed to die. No, these patients should be sent to surgical teams who are qualified to treat these patients, and they should get surgical treatment. It has been shown that patients with ischemic cardiomyopathy with evidence of viable myocardium and vessels amenable to bypass have an 88% perioperative survival, and I think that is excellent. We shouldn't let these patients die, and a 72% 1-year survival. So if a patient has a bad heart, don't let them die. Stitch was a big trial for treating ischemic heart disease surgically, and it showed that if the heart dilates, the risk increases, but yet these patients have a better quality and a better outcome than when treated purely with medicine. So instead of medicine alone, CABG and medicine has better outcome in patients with LV dysfunction. Again, creatinine. We all should look at creatinine of patients. If the creatinine is very low, they are very high risk, and creatinine is high, they are high risk. But still, these patients should be subjected to surgery. And patients who have mitral regurgitation, this is something that's not very commonly noticed by people. But if any patient has a dilated heart, he starts getting mitral regurgitation. So when they are sent for surgery, if there is mitral regurgitation, it should be corrected, because if there is a residual mitral regurgitation or the mitral valve is leaking, then these patients have a higher mortality. So it's very important to treat everything on the heart. Do a bypass, correct the size, correct the shape, and correct the valve. I'm sure all of you know which is the girl you would prefer. The girl on the right, she looks more pretty. So same way about the heart. The heart has to have its correct size and shape. If the heart shape is bad, it won't contract blood properly. For example, if there is a big aneurysm like this, the heart is not going to have a forward flow. So very important is surgically try to correct the size and the shape of the heart when the patient comes for bypass surgery, and this definitely helps. If one wishes, we can do a thallium, but usually an echo is more than enough to decide whether the patient needs surgical ventricular restoration or not. So this is how we do it. If you've got a patient like this, we open the heart, we put a balloon inside it, and we correct the size and the shape of the heart. And the patient's ventricle, once it is restored to the normal size and shape, it does much better than a dilated heart. These are a few examples where we've opened the heart and we put, this is a big heart, clot is removed, a sizer is placed, and the heart is corrected. And these patients do very well long term, and they do better with medicines and surgery than medicine alone. Shape is very important. So we use a balloon, a mannequin inside the heart to give it proper size and proper shape. We cannot leave the heart big, we cannot leave the heart small. It should be correct size to have a good result. So what I'm saying is that if a patient has a failing heart, with a huge heart, with the dyskinetic segments, a proper balloon placed surgical ventricular restoration is good. Our team itself has done around 800 ventricular restorations, and we've had excellent results. I don't have the time to discuss that right now. Sometimes there are big lateral wall myocardial infarctions. We can correct them with simple pegylated sutures like this. Second is treating the mitral valve. If we leave severe mitral regurgitation alone at the time of surgery, then 30 to 40% of these patients will be dead at 1 year. So if you have a patient with a bad heart, with ischemic heart disease and mitral regurgitation, treating the MR will reduce mortality, and hence these patients should be sent for surgical treatment. Basically, the heart dilates, the papillary muscle moves down, and regurgitation sets in. Just put a ring, correct this regurgitation. The simple thing has to be done. A small ring is placed, and this helps treat. Just a simple ring like this can help, reduce the annulus again, make the mitral valve competent, and once the MR is gone, preload on the heart is gone, and the patients do very well. I have had patients who come with 10% EF, severe mitral regurgitation, very sick, class 3, class 4. We put a balloon pump, take them on the table, do the grafts. I did one yesterday like that. Put a ring, correct the mitral regurgitation, and after a few months, the ejection fraction is back to 30-40%. They are asymptomatic and they do extremely well. So these are the treatment options that should anyhow be at least considered for your patients who have a bad heart. Correct the mitral regurgitation, correct the ischemia, and correct the size and shape of the heart, and they do very well. However, patients who fail on this also can be offered devices like left ventricular assist devices. These are devices which will suck blood from the left ventricular apex and send it to the aorta. So these can be used as, destination therapy, where they will be permanent treatment. Just implant the device and forever he can live with the device. They can be bridged to transplant. Put a device right now, and maybe when he gets an organ, remove the device and get him okay. Or they can be bridged to recovery. Put a device, let the heart recover, and remove it later on. These devices, I'm just mentioning this because these devices are now available in India, and in patients with end-stage heart disease, these can be offered in Ahmedabad also. And average cost for a device will be between 30 to 50 lakh rupees. Yes, it is expensive, but these therapies are likely to get cheaper, and they will be offered. It's something like this. There's a machine implanted, there's a battery that's worn outside, and these devices are available and will be offered to patients. The prices are steadily coming down. And any day, these patients have a better survival than end-stage heart disease who don't have a device like this. Coming to stem cells. Stem cells is like the holy grail. It will be the final treatment for heart failure. something or the other in stem cell therapy will be available in time to come. So stem cells can be taken from the bone marrow, they can be taken from the blood, they can be coming from the muscle, and they can come from cardiac tissue. And we also did our small little experiment using stem cell, but somehow we were not very successful. The day it gets successful, I'm sure that will be the final cure for heart failure. Many mechanisms have been suggested for how that can help. It can help by regeneration of myocardium. It can help by revascularization of myocardium because of the stem cells. It can help by just increasing the local thickness and preventing dyskinesia of the local myocardium. Multiple mechanisms have been mooted, but we are not sure how well they work. But with time, I'm sure there will be a day where stem cells can be used. Total artificial heart is something still on the horizon, but not there. But one day I'm sure it will be available. Maybe 10, 15 years down the line, it will be a normal thing. If a patient needs a replacement, instead of a transplant, they may go for a total artificial heart. And I'm sure the way technology is going, it will be there one day. We never predicted we'll have these type of mobile phones which will do everything for us. So I'm sure one day these devices will be available. Many hearts are under trial right now, and we are not sure when we will get one, but we will get one. Coming to the last part of my talk, heart transplantation. This is, of course, a big thing nowadays, and with more, all of you know, every other day it's in the press, there is a brain dead person and he donates all of his organs, and from one donor, at least 7 to 8 patients get a new lease of life. So heart transplant is something that's going to come, and it will be given for most of the patients with chronic heart failure. Like, for example, young boys, or means young patients with dilated cardiomyopathy, end-stage heart failure. They are initially treated with Milrinone and other drugs, prepared, preoperatively evaluated, and taken up for heart transplant. However, there will be some contraindications, like patients who have got hepatitis, viral infections, those who have advanced liver disease, those who have kidney diseases, uncontrolled diabetes, end organ disease, severe pulmonary hypertension. In fact, pulmonary hypertension is a contraindication to transplant. So there will be some diseases for which we will not be able to offer transplant, but most of the young patients, as the organ availability keeps increasing steadily, we will be able to offer transplant to more and more patients. And it is the real end treatment for heart failure. While the patient is waiting for transplant, it is necessary to optimize treatment, Milrinone, diuretics, and just as Dr. Gupta said, ARNIs, they have been a big change. Even the price of ARNIs are likely to go down because the patent period for the drug is now over. So we will be able to use a lot of drugs, treat these patients, and only once they fail on drugs, we will need to offer transplant. The only problem with transplant is that after transplant, there is an aggressive immunosuppression therapy that needs to be followed by the patient, and they have to be careful of not getting incidental and accidental infections. So we can have primary graft dysfunction, we can have rejection of the graft, you can have infection, and one of the most common problem is delayed graft vasculopathy. That is the heart that has been transplanted.
1 minute left, please.
Yes, this is the last slide. The organ that has been transplanted is susceptible to getting vasculopathy. That is, coronary artery disease is very common in the transplant graft that has been given to the patient. So that is another problem. And of course, malignancy is frequently seen in patients post-transplant. So in conclusion, I would like to tell you that heart failure needs an aggressive treatment. Either it is medicine or it is surgical. So medical treatment at one time may fail, and it is very important to offer some sort of an advanced treatment to your patients who fail on medical therapy. That can be bypass, valve replacements, valve repairs, and ventricular restoration. And this makes all the difference to the patient. And those who cannot have these surgeries should be offered transplant. Thank you so much.
Thank you, Dr. Anil Bhai. It is a nice talk, and from that we can conclude that failing heart should not be a problem, and it should no stone should remain unturned for that. And now I ask Dr. Shailesh Bhai to give prize to Dr. Anil.